welcome to the Psychiatry and Psychotherapy podcast, with over 32,000 mental health professionals listening every episode. Why? Because we need to stick together to survive the mental health field. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. Okay, welcome back. I am joined here with Dr. Ariana Cunningham.
Hello.
She is a psychiatry resident. We previously did an episode on schizophrenia, the cultural aspects, how it's in the film, the history of it, and now we're going to dive into clinical manifestations. So where do you want to begin?
So I think first off, just paint some broad strokes. When we talk about clinical manifestations, there's usually terms thrown around like cognitive impairments, social occupational impairments, positive versus negative symptoms. And we're going to dive into each of those to kind of explain what that really means. And also to give some helpful tidbits as far as which ones are more common, which ones are less common, and what you would even expect as far as the timeline of which ones would you expect to show up first. So something that we, I think, talked about last time in the other episode as well is that when we look at impairments, we think of cognitive impairments coming before the onset of positive symptoms, an example of a positive symptom being like a hallucination. And that when we think about the positive symptoms, because these are maybe the most famous of what you think of, we're talking about hallucinations, delusions, disorganization. So maybe let's dive into these positive symptoms and then kind of go stepwise from there.
Sure, yeah.
So positive symptoms, hallucination, general understanding, you could say this is the perception of a sensory process in the absence of an external source. Auditory, visual, somatic, olfactory, aka something that you smell, or gustatory, something that you taste, versus a delusion. I think it's really helpful to kind of differentiate between those. A delusion is fixed false belief. They can be bizarre or non-bizarre, like it can be something that seems like extraterrestrial beings or a perception of something that maybe really could happen in real life. But they can even be further subcategorized with grandiose, paranoid, nihilistic, and maybe it's helpful to kind of say here that the delusions is something that's really common in schizophrenia. And per some studies that I was reading, they approximate like 80% of people with schizophrenia, you'd expect to see a delusion there.
Yeah. So the most common hallucination is auditory hallucination.
Yeah.
Most common for men in studies is that you're gay. And for women, it's that you're a slut or a whore. So these are bad, negative messages that are coming to the people over and over again throughout the day. And then the delusions, usually when they come to you, they may not directly tell you the delusion. They can be fairly guarded about the delusion, but their behavior may show you the delusion. So they won't eat anything in the cafeteria that is not from
wrapped or
wrapped. They often, I think probably the most common is the paranoid delusion. So it's the delusion of people are after me, but there's also the grandiose, like I'm Jesus or I'm Mary, mother of Joseph. So usually you'll have delusions and auditory hallucinations together.
Yeah, those are sort of, like we said, delusions you expect in 80%, and then when you look at the hallucination, auditory more common than visual, which is different from how it's represented oftentimes in film. And then kind of the next thing that we'll look at is disorganization. This is including both behavior and speech. And I think a lot of us, even if we haven't worked on an inpatient psychiatric unit, sometimes you'll see people acting out or speaking out in really abnormal ways. But I kind of want to give you some tools to understand if you have someone and you're trying to understand what kind of speech pattern are they displaying. It's definitely disorganized. Here's some kind of helpful ways to subcategorize that. It includes tangential speech, and this is really just think of someone when we talk about going off the tangent, increasingly further from the topic without really answering the question. So if I ask you, what's your favorite food, and you start...
My favorite food, let me think about my favorite food. Today I was at the grocery store, and at the grocery store I saw this boy, and the boy was wearing a black cap. Black cap. When I was in the military, there was a man with a black cap.
This is a sort of like patient interaction that you might have where it's really difficult to get through your list of questions. You have to like reel them back in, kind of help redirect, but that's considered tangential speech. Versus circumstantial speech, which was something that I remember being a student having to kind of map out visually. Mm-hmm. Tangential, they're going off the course. Circumstantial, they wander off the path, but they'll eventually get back.
Yeah, kind of like a circle.
Yeah. Next up is the term is derailment, which is kind of suddenly switching topic without any logic or segue. Versus, like earlier, Dr. Puder, when you were doing the tangential, there was connection points that would lead you from one to the other. Whereas derailment, you may not really be able to follow what's connecting those thoughts for them.
Yeah, kind of like the letter I read.
Yeah.
It's like, okay, how do those thoughts connect? They didn't really connect.
No.
Yeah.
And then next up, neologism. So this is just the creation of a new meaningless word that they might use and apply some significance to. I haven't often been present with patients who displayed this. I don't know, have you?
Yeah, me neither. Yeah, but it's there.
Yeah. One that I definitely have witnessed is word salad, and it is just what it sounds like. Words kind of jumbled together without sensible meaning, without being able to follow it. And then verbigeration. This is a meaningless repetition of words, sentences, or associations. And that might even be a little bit in what we saw in that letter that you were kind of remembering there.
And one little interesting thing to note about this is that when psychiatrists are called in to do forensic examinations on patients, and they're asked to, is this patient schizophrenic? And the schizophrenia was part of the cause of the murder or whatnot. It's really hard to fake this all the time. So it's a lot easier to fake like, oh, I'm seeing things or I'm hearing things or delusions. But it's really hard to fake this 24 hours a day.
Yeah.
It's just almost impossible.
Sounds mentally exhausting.
And this is really what separates, like if you want to separate someone who's borderline personality disorder, sometimes they can be hard to differentiate. But someone with borderline personality disorder will not have these things.
That's really helpful because as you sit down to interview a patient, if you try to, I remember I had one attending who was like, don't put too much in what you see in the charts. Go try to see and engage with them with a fresh open eye or in this case, ear, and just really try to notice patterns that are displayed in front of you. And
what I would say also is if you are working as like a psychiatric nurse, don't put down patient is having word salad or patient is having tangential speech. Put down in the chart what is actually said, if possible. Like, patient said this, quote, blah, 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 blah. And in that, it'll show very clearly the severity of what's going on, more clearly than just a word.
Yeah.
So often, if you're new, if you're a medical student, if you're a resident, and you're having this in the HPI, just put down what they're saying.
Yeah.
And how they're connecting. Patient connecting the mind calendar with quantum physics and this and that. And it's like, put down that stuff as it is heard. And sometimes try to put in quotes because that will be the most interesting stuff. Okay, so instead of putting down person responding to internal stimuli, put down in the chart patient batting their hands in the corner of the room at something that's not there while yelling profanity.
It's such a more vivid picture and understanding of what's going on and the severity because RTIS, responding to internal stimuli, really has such a broad range of what could be manifesting.
Yeah.
We like specifics.
I like the pictorial imagery. Okay.
So next up is what we'd call negative symptoms. Earlier when we were doing the broad strokes, understanding there's negative and positive symptoms of schizophrenia that are considered to be sort of typical to the disease itself. When we talk about negative symptoms, you can kind of differentiate into two subcategories, being one that is a diminished expression when we think about like emotionality, and the other one which would be kind of like a loss of motivation, what they call like the avolition apathy cluster. So avolition or the apathy concept is just a decreased motivation to initiate or perform self-directed, purposeful activities versus some of the other things we consider to be in the negative symptom category like anhedonia, affective flattening is just a decreased emotional expression, and you might really sense that when you're interviewing them, almost this lack of emotional energy that you can read from them.
There's sometimes like a flattening or blankness, and the lack of motivation to initiate. Some of these patients, if you watch what they're doing, they're really just kind of sitting there. They're not really interacting with other people. They're just they're not doing anything.
Yeah.
They're just lying in bed. They're just, there's no real interaction or seeking of interactions in the negative symptoms. And the negative symptoms are harder to treat.
Oh, yeah.
Than the positive symptoms. And sometimes, antipsychotics can induce some of the negative symptoms because of the blocking of dopamine,
Yeah.
But these things will be there anyways. So it's definitely from the disease, but the medications are not going to necessarily help.
Yeah, and that's important because I think I hear a lot from patients or their family members this fear of becoming, quote, a zombie on medications, but to really kind of look at the cost benefit and see what the actual disease itself comes with, a lot of those things as well.
And, I think clozaril uniquely can help some of these types of symptoms. And we'll get to more of that in the future when we talk about this stuff. Okay.
So then the next category is what we consider cognitive impairment, and that includes like mental processing speed when you see someone try to engage in a problem or respond to a question, and you might feel that there's a certain amount of like sluggishness. Same thing with verbal or visual learning and memory, reasoning or executive functioning, verbal comprehension, social cognition, kind of this pattern where you might see just feeling things are a little bit slow. And that can be present in other mental health conditions as well. But it's something that's, at least from my experience, can be really tangible when you interview them.
Mm-hmm. Yeah. And it's interesting. I've had a couple high-functioning schizophrenic patients that I've had the real pleasure of treating who have done well on clozaril, on Zyprexa, and, you follow them for a long time. And they're able to do well. They're able to go on and get straight A's in college, go on to professional degrees and do well. And so although this is an issue, some people will have it more than others. And I think with the proper treatment, you can really optimize things more than you might consider. I would say also with cognitive impairment, like if you have someone on Cogentin because you're worried about preventing EPS, or, like with a medication with a dopamine blocker.
Yeah.
The Cogentin itself can cause some of this as well. So that's sort of anticholinergic. So, moderating the anticholinergic burden can lessen the cognitive impairment. This is where there's a lot of nuance in psychiatry. It's like you both can cause some of the symptoms, but you can also have the symptoms there from the disease.
Yeah.
So we have to try to optimize everything we can. And a lot of that happens outpatient, right? So inpatient, you're trying to get this guy out of psychosis. You only have a limited amount of days because the insurance companies want to get this person out of the hospital. And so you're really trying to get them as quickly as possible out of psychosis. And then once they're out of you're following them outpatient, it's like you're able to make nuanced, small changes to optimize their cognitive function.
And then another thing that I think is really important to touch on here is that schizophrenia sometimes doesn't manifest in and of itself like an island away from the other conditions that we see in mental health. And actually, mood and anxiety disorders occur at a higher rate in the population of people with schizophrenia than in general. So there's a few different studies that I'll post up, but we see a lifetime prevalence of depression in the schizophrenic population fairly varied, but it definitely does occur at a higher rate than the general population, along with a higher rate of suicide than the general population. 5% of 10% of all completed suicides are among people with schizophrenia is kind of one pretty sad factoid. Another study outlined that there's a high comorbid anxiety disorder prevalence, and that includes like social phobias in about 14.9% of the schizophrenic population, PTSD at 12.4%, and OCD 12.1%. And then kind of conversely, they found in some studies that people with OCD, social phobias, or panic attacks had an increased odds of developing schizophrenia. I don't think I'd want to say this in a way to scare people out there, but I think it's more of a softening for those of us in a treating position to have your eye out for other things going on that might be adding to kind of the level of dysfunction or how difficult they are in regaining certain functionality levels with treatment, that we don't want to miss these things.
Yeah, I definitely have seen the social phobia, and it's hard to sometimes discern, is this the paranoia?
Yeah.
Or is this, and then once you have the paranoid treated, is it the anxiety underneath with the OCD, the obsessive thoughts? If they've been on the antipsychotic for a while and they're no longer having the positive symptoms, but they still have these repetitive, distressing thoughts, it can almost seem similar to the intrusive auditory hallucinations, but they're not the same. Mm-hmm. They're repetitive. They want action, and they have compulsions that follow sometimes. So it can be a little bit hard to discern and delineate what's what, but really getting a full history, I think, is really helpful.
Yeah.
In making that.
Yeah. And then another thing that was actually pretty interesting and new to me as someone kind of young in this field right now is some associated physical manifestations, including what are called soft signs, or the neurological signs that sometimes you see with someone with schizophrenia. So it includes some impairments on sensory integration and motor coordination. There's some examples of right-left confusion, the inability to identify certain familiar objects. And granted, I think like you were saying, you really have to parse out what is a manifestation of a different aspect or a different symptom of the disease, and what is this in and of itself. The inability to recognize letters or numbers if they're traced on the skin, that's pretty specific sounding, but it's something that's really talked at least about in literature. I don't know how much you've seen of this in your practice, Dr. Puder.
Yeah, that's interesting. Some of this stuff, I probably don't look for it enough.
Yeah.
But it's interesting how coordination, movement, right, which is all sort of dopamine, mm-hmm. Is influenced by this disease as well.
Yeah.
You have the mesolimbic tract, mm-hmm. which is where the schizophrenia tends to occur. And then you have the nigrostriatal, which is where the movement occurs.
Yeah.
And so in Parkinson's, when you have a deficit of dopamine, you get very stiff and rigid and slow movements. And so it's interesting.
Mm-hmm. And that kind of ties in that some of the neurological disturbances, like you mentioned, could be more so in relation to, let's say, an adverse drug reaction. So it's important to differentiate, did some of these things, if they're having tremor or bradykiniasias or acute dystonias or akathisia, were these things coming on before you started meds, or did they only come up or worsen after starting certain meds? And just really keeping an eye out for the things outside of what we consider to be those core, positive, negative symptoms, hallucinations, etc., to keep an eye just so we can really set people up for the most success possible.
Yeah, and this is where, I think there's a benefit of seeing someone long term.
Mm-hmm.
You put someone on a medication, and then the next day they're very restless. It's okay, you probably caused that from the medication. Mm-hmm. And so, akathisia, internal, external restlessness, something we have to continue to monitor, continue to make sure that we're not causing that issue, because that is so anxiety provoking.
Oh, yeah.
It's torture. So, if they have it, I've talked about this before, but propranolol, mirtazapine, Klonopin are really the three treatments if lowering the medication is not an option. There are certain antipsychotics that cause it more often, and there's certain that cause it less often. So switching it to one that causes it less, or, listening to a good history from patients, what caused more of a restlessness, what didn't cause a restlessness. But akathisia is one of those things that I constantly am looking for, because if you miss it, you're going to miss this really, really debilitating and painful thing that we are causing essentially from the antipsychotic.
Yeah.
A lot of people who are very resistant to antipsychotic, if you get a good history, it's actually probably because the antipsychotic they were put on caused akathisia. And so it's something that I'm going to do a full episode on it in the future. Okay, let's keep going.
And then another thing, kind of when we imagine a patient with these symptoms presenting, with these different manifestations, another thing to really think about is catatonia itself. So we're going to post up, it's called the Bush-Francis Catatonia Rating Scale, that oftentimes my initial imagery of what catatonia looks like is someone who's like blank slate, not moving, like stuporous gaze, but there's a lot more to it. And I think that this rating scale, it has 23 kind of, I guess you could say, categories that you go through. Examples including excitement, immobility or stupor, mutism, staring, posturing, grimacing, echopraxia, stereotypy, mannerisms, etc. It's a pretty good list.
Echopraxia, repeating the same sentence over and over.
Yeah.
That is just, if you catch that, you're an all-star. If you've caught that, let me know. It's, you ask a question and then they may repeat the question or answer the question. And then you ask another question and then they'll repeat themselves again. So yeah, catatonia.
Yeah. So definitely take a look at that rating scale because it's different than what maybe we see once again in film, what kind of colors our perception of what something looks like. That when you have someone who's exhibiting a lot of negativism in terms of like the symptoms that can be associated with schizophrenia, to keep that in mind.
And catatonia is, we treat it differently.
Yeah.
Okay. And so catatonia is like one of those things that you're going to want to know in your mind, that pattern. You're going to want to be able to see that. It's a great diagnosis. It's a great diagnosis for the people, on Twitter and all the antipsychiatry people out there. I often think to myself, okay, you treat a couple catatonic depressed patients or catatonic schizophrenic patients without meds, and you let me know how that goes.
Whew, yeah, I cannot even imagine.
Or like ECT can be really, really helpful for when you catatonic depression.
Yeah.
And if you've treated these patients, you've tried other things. High dose of Ativan can be really, really helpful. I mean, high dose, like up to 18 milligrams. Like a normal adult will get like 1 milligram 3 times a day.
Yeah.
For like alcohol withdrawal, or like 2 milligrams 3 times a day. So like 18 milligrams a day, that's a big dose of Ativan. You don't go up there all of a sudden. And if you give them Ativan and nothing happens, it might be a lower likelihood of having catatonia. So read the list. We'll put that up there.
Yeah, it's important I had an attending who was both a JD-MD, so he's both a lawyer and a medical attending, and kind of this sense of there's certain things you would never want to miss, not just for the care of the patient, but also from a legal standpoint, that if you're treating and going down one path and didn't consider this alternative, that could have a lot of ramifications.
And when you look at the history of psychiatry, a lot of the patients they're describing, I feel like the severe cases, before medications were around, this is what was going on.
Yeah.
Because catatonia may be like one of those like final common pathways for like really, really severe mental illness. And it's sad that someone could get locked in. Like people with catatonia, I've had people that I've caught who stop drinking, who stop eating. They've lost, 20 or 30 pounds in a month.
Oh man.
And they're slowing down. It looks like severe Parkinson's disease without Parkinson's disease. Like they're so slow, they're walking around, they're talking slow. And then the catatonic excitement could be the other end of it.
Yeah.
So.
It really doesn't look how I first imagined it. The first time I printed this off and took it to bedside, I was like, oh my goodness, I never even thought. Well, another thing that I did want to mention is some of the metabolic disturbances that they've found are linked to or, have a higher prevalence in the population with schizophrenia. And that includes diabetes, hyperlipidemia, and hypertension. And kind of unfortunately, and I'm sure even as we've discussed with the support system and maybe difficulty with follow-up, this could be a part of it, but the life expectancy for someone with schizophrenia is actually reduced by 10 years in comparison to the general population. And the main medical mortality, and I'll post up the article where this was outlined, is heart disease. So, I mean, when we consider support structures and medication compliance, this isn't just for the mental health itself, it's for the whole person and all of their medical comorbidities.
Yeah, and type 2 antipsychotics, second-generation antipsychotics, increase the risk of metabolic disease. And so one of the big things that I do for patients is I try to get them on an exercise routine.
Yeah.
Once they get more stable, once they're not hearing things, once they're on medications and they're stable outpatient, get squatting, get deadlifting, and I'll remind them almost every visit of the importance of it. And the ones that do it, it's like so good because how does diabetes progress? Well, it starts in your quads, probably 10 years before you actually get uncontrolled glucose, and so having an exercise routine will be so helpful. But in your study, in your look on this, it's not just from the medications. Is that what you're finding?
I mean, yes, there are components where some of the medications that are used to control schizophrenia and its symptoms can have an effect here, but it's also outside of just as a medication side effect, which is important to emphasize. Plus everything we talked about with if you have a person who's experiencing homelessness and schizophrenia, like that combination and medication follow-up and regular visits and even glucose monitoring, just all those things. I mean, treating the schizophrenia and getting them as functional as possible is all you can do to help with these other things that are associated. Like, it's really, I think it's crucial for every aspect of their health.
I once called to the ER, and there was a patient that had psychotic illness. And as I spoke to the patient said that they had worms crawling on their legs. So I looked at their legs, and lo and behold, the patient had cellulitis. I called back the ER doctor, and I said, okay, have you thought about their infection? Yeah. They're like, what infection? So often people who have psychotic illness, the way they describe their physical illness will be twisted with psychosis involved with it, which will not get them the treatment that they need. So there's a bunch of things leading to this, I think, 10-year. Part is just like advocating for themselves. How do you advocate for yourself in the same way as a normal person if you're acutely delusional or psychotic?
And if your complaint of chest pain and frequent urination is embedded in your, paranoid delusions that you're expressing, it's easy to see why a provider might kind of, already start disengaging and not pay much heed to the actual content of what they're saying. But
yeah, or a lot of people who are on the street, it's like they're paranoid to the point that any pill is poison. And so, they're not going to take a medication, any medication they're not going to take. Yeah. Whew. Okay, so disease course.
Yeah, so this is, I know we've kind of touched on this, but typical onset, young adulthood, we think 21 years old for males, 25-year-old for female. If it's occurring outside of that range, your index of suspicion that this might be something else gets higher. There was a really cool person, Manfred Bleuler, in 1972, and then later studies kind of helped take a look at basically the pattern of the disease course itself and looking at when the symptoms onset and how the outcomes go. And when we talk about onset being abrupt versus insidious in this particular disease, they found like an overwhelming majority had an abrupt onset when you talk about the symptoms. But again, kind of like we said earlier, is that oftentimes you would expect some of the functional or cognitive deficits before a positive deficit like the hallucinations, which are much more apparent. So I think even in reading this, we need to have some index of suspicion of what people are catching as far as this abrupt onset versus all those precursor signs.
Right. So abrupt is like 80%.
Yeah.
Insidious is like 20%. So most of the people, like the first symptom is that is going to get noticed, right? Yeah. Is that psychotic symptom.
And it's good that to become really familiar with the different symptoms and how they present, because the main studies that we've found is encouraging in the sense that timely and intensive treatment can impact functional recovery. Really cool study kind of outlines these things that I'll post up, but that really being able to have a good eye for catching this is really, really helpful and could make a huge difference in the patient's life. So they had a really fun study that was following people after 2 years who had an intensive intervention and showing that they had a greater improvement as far as functionality at school, work, less psychopathology. Just a interesting randomized study with 34 community health centers in 21 of the United States, and basically looking at different types of intensive treatments and going into that. We'll get more into those details in the future as far as what treatments can maybe have some support for making a bigger difference or impact. But
the key here is early treatment, and intensive treatment that involves the family, the stress that's going on in the home. Can we reduce the stress in the home? Can we get them on the right medications? Can we get them some psychotherapy? If all those things take place, the long-term trajectory changes.
Yeah, it does.
And I've seen this. I've seen patients who have had, they're in and out of psych hospitalizations, and every time they have a psychotic illness, there's damage to the brain going on. And then compare that to patients who early on, they get, first break psychosis gets sort of identified. Early diagnosis of schizophrenia, get them on the right medications. They don't need very high medications. And then I followed these people, and they do so much better because their cognitive function is not attacked by multiple psychotic episodes.
Yeah.
Which I think really does damage the brain long term.
Oh, yeah. I have an attending who you probably worked with as well, who gives the analogy that being in an active psychotic episode and to some degree an active intensive depressive episode or these different things are like small bouts of traumatic brain injury being inflicted on you with each round. So if we can decrease the number of those before treatment isn't put in, or, avoid as many of those as possible, we're saving their functionality for future.
Absolutely. Okay, so we're going to wrap this up today. So what are the biggest sort of aha moments that you had when researching this part?
I think the biggest aha moments is really that schizophrenia looks different than what we imagine sometimes, and to have your eye out, not just for visual and auditory hallucinations, but for the negative symptoms, for the cognitive delays, for the different speech patterns that really, your mental snapshot, if you were to close your eyes and imagine someone that, let's say, you've encountered in whatever setting as a provider or as a pedestrian, what have you, where you're like, this person might have schizophrenia, and then to really expand that picture so that someone doesn't kind of fall through the cracks when you could really change their life trajectory.
Yeah, and I want to leave people with hope that if properly treated, people can do so much better if they can get the proper treatment, if they can, if you build a strong connection with them. And it increases medication compliance. So therapeutic alliance, medication compliance. I see it because there's some people I connect really well with. There's some people I, have a harder time connecting with. It changes medication compliance. And then, how can we also integrate the family into the treatment through psychoeducation? I'm hoping that this episode can provide some psychoeducation maybe for families that are out there listening to this. And then looking also at the comorbid diseases. That's what we talked a lot about. We talked about social anxiety disorder and PTSD and obsessive compulsive disorder also being present there.
And then there are metabolic ones as well, and cardio.
Talked about the importance of looking at the metabolic, continuing to screen for metabolic issues. You should be running labs consistently over the course of treating these people long term. And also I would say, if new symptoms arise in a person that was previously stable, did something metabolic happen? And keep that in your mind as well. And, I had a patient develop diabetes, and it changes the treatment.
Yeah.
Luckily, this person was just on a steroid dose, an oral steroid dose for a really bad asthma attack. And so the diabetes sort of was not really diabetes in the end. It was a steroid-induced hyperglycemia, but it increased their anxiety quite a bit, having their glucose that high and being on the steroids as well, probably. But it's kind of like, as we approach this population, to think through, okay, is it medical issues? And to not be distracted by only psychotic symptoms. So that would be another big sort of aha moment I hope that you would have as well, is that you would actually consider, oh, maybe there is medical issues going on that are making or defining how they will psychotically present. Okay?
Yeah. And we'll dive more into things like smoking and how that affects things, different substances, how that affects things. But there's just so much.
We got a lot to go. Okay, so this is going to be the schizophrenia series. Like I said in the previous episode, we're going to have some of this on YouTube with like video clips. So if you haven't checked out my YouTube and subscribed to it, go over to I think it's Psychiatry and Psychotherapy. There'll be links from my website, from the show notes of this to that. Also the Instagram, if you haven't joined the conversation there, for every episode, I put a post up and people put up comments and try to create some interaction. That's kind of the biggest place to interact with the people who enjoy this podcast. And really good job, Ariana, pulling some of these notes together.
Oh, yeah. And we'll post up all the links. So if you have questions about the articles we reference and things like that.
It'll all go in the resource library.
Yeah.
And we'll have a blog that goes with the episode kind of talking about it as well. So, all right. Thank you.
Cool. Thanks for having me.